Um, myself and my husband, who is from this area, we were involved with a small group of students and doing little like some sort of exhibitions, poster exhibitions, little drama programs about health awareness and health education as well as other things. And so it was a very low key. Then I think the major turning point was in 1994 when in the middle of the night I was asked to go and help somebody who was having a baby in the village. So I tried to, you know, I sort of refused and said, I don't know anything about childbirth and go call somebody else. And so it was, they didn't know who else to call. And I said, why don't you go to the government hospital? And I mean, I'd been in the village then for 5 years, but I really knew that the government hospital wasn't up to much, but I didn't know that it was actually closed in the night and they were not attending to childbirth at all. So then I asked them to call the traditional midwife. So the traditional midwives also, it was a time that the traditional midwives were dying out. So they wouldn't come in the middle of the night either. It was a time that the, village quacks, RMP doctors, Jolachap doctors, whatever you want to call them, they were moving into childbirth. And they were giving injections of oxytocin and trying to get babies out. And, so they were moving into childbirth. The traditions were dying out. There was no alternative. So it was 5 men standing at the door saying, come, 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 come. So I went along to my first birth with a book. I don't know whether you've heard of David Werner's Where There Is No Doctor. So I took this book along with me. And fortunately, or I think fortunately, the baby, nothing happened, and the baby was born, and I didn't really do anything. But when I walked into this room, little room in a mud hut in the village, and there was a group of 5 or 6 elderly women all sitting around this woman groaning on the khatia. And when I walked in, they all sighed in relief that I'd arrived. And I thought, this is so sad, because they knew I knew nothing. And they knew much more than me, but they really didn't know what to do when this woman was having her 4th baby and why it was taking such a long time. It should not take so long. They didn't understand why it was taking so long. So they panicked. And I felt really quite shook by this. I'd been in the village for 5 years by then, and I'd been sticking my head in the sand. And so the next day I went back to the house and I asked all these women, what do you do when you have some complication? Who do you call? Where do you go? And they had no answer. Then around a few days later, I decided to call a meeting of all the women in the village. So they all came to our house. Around 50, 60 women came. And I asked them the same question, that what do you do when you have a complication or a problem? And nobody had any answer. So then I thought that, the time has come I should start addressing this problem. Unfortunately, after that, or fortunately, whatever, people kept on calling me for births at home. Then I realized I need to learn something. So I tried to learn as much as I could, and no untoward incident happened. But then I realized that, attending births at home was not really what I wanted to do. And at the same time, the village women were getting organized. Around the same time, we started setting up women's self-help groups. So we had women's self-help groups, a handful at the time, but they were growing rapidly, and they were making demands that, we're fed up of not having any care during childbirth. We're fed up of dying and our babies dying. So they had lots of questions about reproductive health problems and menstrual problems and women's problems that they had nobody to talk to and no answers I could give. So we decided to organize a mela in the village. So we called my friend from Calcutta, couldn't find any local doctor to help us. So our friend Dr. Amita from Calcutta, she came and we had a mela, and it was hugely successful. And she examined over 100 women and answered all their questions. And afterwards, the women said, you know, we had another one the following year and another one the following year. And then following that, they started getting more demanding. This once a year event is not good enough. Let's have every month we'll have a mela. I said, well, you know, a mela every month, it's not a easy task to organize. But anyway, we started organizing monthly health clinics in the local school. And at the same time these things were happening, our women's groups were also growing and growing, and their demands were also growing and growing. So after 3 years of having these monthly camps in the clinics in the school, it was on a Sunday when the schools were closed. So they said, we want our own space. So there was no, I don't think our organization was registered, but we had no external funding or anything. It's a very low-key organization. But we hired some rooms on the roadside above a row of shops, and we opened our first women's health center there. This was in the late 1990s. So around the same time, I did help do a study of childbirth in the villages where our Mela Mandas were. And we found that something like 95% of births were happening at home. Over 80% of births, they were calling village doctors, so-called doctors, for giving injections of oxytocin. And maternal and neonatal mortality rates were very high. This was 1997, we did this study. A lot of other things we also found that were not helpful for women or children's health. They had some of the local traditions of not feeding women for 7 days after the birth was one. And another was they would give goat's milk to the baby for 3 days. They would not give mother's milk. They would eat less during pregnancy in order to have a small and easy delivery, small baby and so-called easier delivery. So these were many of the practices in 1997 which we found. So this is where we started from. By 97, we had our own health center. We had around 2 or 3 or 4 births in a month. And we started this first center. We paid for the training of 2 nurses to go on. One was already a qualified nurse who had been out of practice for quite some time, so she needed skills to be upgraded. And another one was a young village woman who was eager to learn. So we sent these 2 women off to learn better midwifery practices in a nearby nursing home. Actually, many of the things they learned in the nursing home were not really, in retrospect, at the time I didn't realize it, but in retrospect, many of the things that they picked up were not hugely beneficial. Anyway, when they came back, so we set up the center. By 2000, the center was too small. So the women in the women's groups, they had a meeting and decided, we want our own center, a bigger center. This is too small. It's not got an attached bathroom. It's not this, it's not that. So they decided that they wanted their own building. So they decided to go and petition the local government. They went to the block. They get out the block development officer, around 1,000 women. I thought 100 women would be there to hand over the petition, but it turned into 1,000 women gathering, and they get out the video until he signed the dotted line that they would sanction a building for our women's groups to make a health center out of. So 2001, the health center started, the new one. So this is how we started. I've got a few notes here. I better go to the second page. Um, One of the things that we have done, which I think is a little unique in our center, is that we have a hierarchy. And our hierarchy, if you imagine an inverted pyramid, and at the top is the community. And the community were organized into women's self-help groups. Now we have around 9,000 members of the women's self-help groups. So there's around 500 of these groups at the community level. Below, they have elected health workers for themselves. This was before the ASHA program started of the government. So these self-help groups, they selected their own health workers who would be their representatives. They would be their link between the women in the village and our health center. Then below we call them swasthakis, the women who were selected. Over 100 of these women we have trained over the years. And many of them are traditional DIs, traditional midwives. Below them we have a set of 9 community health workers who reach out to the swasthakis in their village to do the community health programs. And they are connected to our health center. So there's this inverted pyramid. And at the bottom is our health center. And all these levels of organized women at each level, they connect to another level. And in our health center, we have 16 staff to run the health center. Out of them, we have 12 women who are full-time, and they run the health center. We have very minimal inputs from qualified medical doctors in particular. And one of the things that we very strongly maintain is that it is not a hospital, because a hospital is for sick people. And women who are having babies are not sick. Generally, they're not sick. And pregnancy and childbirth is not an illness. So one of the things we have maintained is that if you put women from childbirth into hospitals, they become a patient. So our women are not patients. They're, on the whole, reasonably healthy. I mean, they're malnourished and little anemic, but they're not sick. And if you put them in a hospital, they become patients, and they're treated as a patients by the medical profession. So this is something that we maintain very strongly. And secondly is, one of the things we have done over the last 20 years, is many of the traditional practices which were actually dying out when we started, over the last 2 decades, I have seen many of them have got validated. Such as, for example, delayed cord cutting is now recommended, or squatting position in labor is now recommended. But 20 years ago, it was not recommended. It was going out. It's episiotomies for everybody. It is, a lot of medicalization was going on. So anyway, so many of the traditional practices were getting validated over the last 20 years. And over the last few years, I've started documenting this. So how far we've been successful in proving that such a group of women in a community, which is really, we don't have a very good referral system. When we started in this block of 2 lakh population, there was no institution, there was no health center for an institutional delivery. Even now in Bokaro whole district, there's no government hospital for 24/7 emergency obstetric care till now. Our Sadar hospital, they don't have a blood bank. They don't have anesthetists round the clock. So if there is a cesarean section in the middle of the night, then it's very difficult. In spite of these difficulties, I want to share some of the achievements over the years. We've had, in the last 13 years, we've had nearly 10,000 deliveries. At the moment, we're doing around 1,000 deliveries a year. And our cesarean section rate is 7%. We have cases of postpartum hemorrhage, and our rate is around 2.2 to 2.4% of women have PPH. Out of women who have PPH, most of them are managed by the women in our health center. Only out over 3 years in the data that I collected, very robust data, over 3 years with 3,000 deliveries, we had 9 women who were referred for PPH to a higher center. Out of these 9 women, 5 were given blood. So out of 3,000 deliveries, only 5 of our women needed to have blood given. We've never ever in all these years had a maternal death. Out of 10,000, over 10,000 deliveries over the years, we've never had a maternal death. Touch wood. It is also, I think it is very cautious and very, we're extremely cautious about any intervention that we do. The less intervention, the better as far as our team is concerned. And we don't want to, for example, our induction rates are very low because we don't want to, we wait and wait and wait. And this is something I think in a hospital, when births are getting medicalized, I think waiting is a very difficult thing to do. I think doctors particularly do not want to wait. In fact, sometimes here when we do have visiting doctors, and we had, until the lockdown started, we used to have consultant doctors coming 3 days a week. And, many times they would, they'd want to rupture the membranes, sweep the membranes, start an oxytocin drip, and like our nurses are like, well, we can wait, if there's, because we have a policy of no intervention without any indication. If it's just because, it's taking too long, then that is not an indication. The availability of an anesthetist, that is not an indication. So we have very strict protocols for this. And I'll share with you another thing is that recently we have been partnering with FOGSI and other organizations to upgrade our the skills and protocols that we have in our health center. And recently we have been accredited by the Manyata FOGSI program as a health center providing quality care during childbirth. So it's, we're not saying, we're not abiding by, established evidence-based protocols. I think we are doing much more sticking to the evidence-based protocols than probably many, particularly smaller hospitals are following. I think, when I look now after, Rupa said, what was the situation like before and what is it now? I think I've mentioned what it was like before we started the health center. And now we've gone from a situation of 95% home deliveries in 1997. And now it's 90% in the villages where we're working, it's 90% institutional delivery. In the villages we are working, in Jharkhand as a whole, it's 60%. But in our area, it's 90%. One of the problems which I identified was this: the village doctors were getting into childbirth in '97 and starting pushing oxytocin IM. to lots of women and causing havoc. That stopped completely. Now, if the babies which are born at home now are not being attended by these village doctors anymore. Many times they leave it too late before calling the ambulance, and because of transportation or roads or rains, they have a birth at home. But it is not because they've called the village doctors to give oxytocin injection. Fortunately, that has stopped. Maternal and neonatal deaths are very, very rare. In fact, only in the last few months, because of the impact of this lockdown, we've had a few maternal deaths because of the inability of families to get to the right place at the right time. As I said, in this district till now, we do not have 24/7 emergency obstetric services in our whole district. The nearest place to us is in Purulia in West Bengal. And during the lockdown, the border between Jharkhand and West Bengal was sealed, so we could not send our women to Purulia, West Bengal anymore. So this has caused some havoc in the health services. So in the last few months, I have heard of a few cases of maternal deaths, which until the last 6 months, it was extremely rare, almost nil in this area. Things like some of the traditional practices which I said were harmful. I'm not saying, I mean, many of them are positive, but some of them are harmful, such as not breastfeeding the babies. For the first 3 days, they would feed goat's milk. This is completely gone. Now, all women are breastfeeding their babies, and they're eating. One of the, I think food is a huge public health problem, and I think it's a maternal health problem. And women are eating. Yeah, so I think I'll leave it here. I think this is a story in a 20-year story in 25 minutes. 1 minute per year. Yeah.
You are muted, Rupa.
Yeah, you are muted, Rupa.
Thank you very much, Lindsay, for the beautiful, mesmerizing story, and actually showing us the mirror act. To be frank, it was very well written by the Sri Devi ma'am that you are narrating the interior part of the story, and unfortunately, we are fortunate that you are here, and unfortunately, being Indian, we didn't know these things. And somebody like you, kind-hearted, take this, as your responsibility to work for these people. And I'm really grateful, and thank you very much, Lindsay, for doing this great job. Everybody is so happy to have you here. Well, I really wanted to ask you one question. Like, it's a beautiful model. So is any other state, any other district, any other part of the country or any part of the world is replicating your model? Did you get any idea about that, Lindsay?
I don't know about replicating the model, but I know my experience with the our Swasthya when the NHRM was being rolled out, and they started talking about the ASHAs. In fact, the first couple of modules for the ASHA program for the Jharkhand government, so I helped write those modules. So I was writing it, keeping in mind what would our Swasthya be if we replicated them all over Jharkhand. So, I pitched it at that level of, not very well educated. In many states, they have, made the ASHA worker to be, she should be at least a matric pass. So in Jharkhand, that rule was scrapped right at the beginning, because in many, many, many villages, particularly the remote villages where you really need these ASHAs, they call them sayas here. If you insisted on a matriculate, then you would have maybe 50% of the villages in Jharkhand wouldn't have an ASHA worker. So the module which I helped to write was based on our experience and the Sasakis. So it's been rolled out to 40,000 Sasakis. Not Sasakis in Jharkhand, they call them Sayas. So to that extent, some replication has happened. But of course, midstream, the ASHA worker here, there was an objection around 3-4 years into the program, saying that the ASHA, many of the things which we wrote in the first modules for the ASHA workers in Jharkhand was to give them knowledge and some skill. I conducted training of health workers in another part in Singhbum district, where the nearest hospital is 12 hours away. And in every village, women were dying. So what level of skills and knowledge does a village health worker need to know in those villages is not going to be the same as in a village which is half an hour away from a city. So some of the things which we put in as, like how to manage a situation so that a woman reaches a health center or a hospital alive. What are the things you can do? I mean, even things like PPH, what can she do? You can raise her legs, you can do simple things like this, somehow to get to the hospital alive. But there was objection around 3-4 years into the program by some people in the medical profession who were part of the government, saying that you should not be giving any skills and knowledge to the ASHA workers, because the job of the ASHA is only to get her to a hospital. If you start teaching her skills and giving her knowledge, then she might do these things at home and not bring the people to the hospital or health center. So there was a little sort of midstream change. So in a way, the model that I had created sort of got defeated midway. But in the first few years, it was there. And I have also similar, in Jharkhand itself, there are organizations that we have trained as health workers, and they come here for sort of experience. And, when we were starting out, we had very bad experience trying to find a place where our women could go and learn. In fact, last week, I was so happy to see Shaibal, because we sent 2 of our women to Shaibal's hospital, Shahid Hospital, over a decade ago, to learn how to manage some of the complications of childbirth. So I was really happy to see him last week on the show. Yeah. Does that answer Rupa's question?
Yeah. Thank you, Lindsay. And my another question is, I'm sorry, and I'm actually putting you in a difficult situation to asking this question. Moreover, it's a live show also. Like, did you find any difficulty or encounter any problem because of the professional healthcare workers, healthcare professionals? And yeah.
Well, as long as you are not treading on anybody's toes, like if we were doing this in a place where we had some competition, then maybe there would be some objections. But secondly, we have always managed to stay within the sort of legal, ambit. We have got clinical establishment. We have got accredited, empaneled under Clinical Establishment Act. We are empaneled as a Janani Suraksha Yojana center. So the births that the women have in our center, we get the money reimbursed for them from the government. So in a way, these partnerships with government, in a way, they need us. I mean, our block is one of the best performing blocks in the district for institutional delivery. Our reports that we submit, our reports are very, very robust. The online reporting that we do, over 1,000 deliveries a year. this looks good for our blog to show that the institutional delivery rate here is so good. So we have a very, in a way, it's a positive sort of partnerships with the government for implementing various general. Yeah, okay. Switched it off.
What happened?
Yeah, because he came with his, like walked onto the screen.
Yeah. Lindsay, I'm so sorry, as I told you in the beginning. So Lindsay, my next question is, your work, your center is the best example of converting challenges into opportunity. So I really wanted to know little bit about your this motivation, from where you get this motivation, because despite being professional, sometimes we feel very low, and sometimes we feel that we are actually struggling a lot to fight with the system, with the processes. So I really wanted to know that you didn't have any healthcare background, and how you managed to do these things.
Um, See, it was never a plan that I do what I'm doing. Okay. I was sort of thrown in the deep end. And, where we are now, I never imagined 20 years ago that we would be running a health center as we are doing, doing childbirths. We are open 24/7. And I never imagined that this would happen 20 years back. It just, one problem, in order to solve it, you add on to it. So it's one I don't know, I don't think I'm doing anything particularly great anyway. It's I'm getting much more from the community than I am giving. I think it's I am benefiting. That's
so nice of you. You are actually, I keep telling people, if you really wanted to be successful, connect your aim, ambition, goal with the social cause. And let me tell you, you are doing the different thing. You are just connected your social cause with your aim, and you are thinking, you are saying that you really want, you are feeling very happy to doing it, and therefore you are keep doing these things. So yeah, there is a question on the chat box. She has explained everything so well. No question. Any significant note on nursing from her end? Yeah, definitely. At the end, we really want a few take-home messages from you, so that we can also, incorporate in our practice, and moreover in our journal life. So another question, I just heard you that you are an accidental midwife. I was just reading that article on you. So I got to know that you got some honorary nursing, probably degree or something like that. Can you please tell me, Lindsay?
Yeah, this was 5 years ago. I got I was made an honorary fellow of the Royal College of Obstetricians and Gynecologists for what I'm doing. Yeah, I was quite surprised that the RCOG would give an honorary fellowship to a non-medical. I thought they'd made a mistake, but I was very sternly told, no, we don't make those mistakes.
And let me tell you, I hope you are the first one, non-medical, who's getting this.
I don't know if I'm the first one. I don't know about that, but it's very rare.
Yeah. So yeah,
Rupa, there's one question in the chat.
Please. Dalmati, can you read?
Yeah. So Lindsay, Lewis wanted to know, Lewis is teaching in a College of Nursing in Delhi. So she wanted to ask any future plans to run the midwifery practitioner course.
No plans as yet. My plan is to make a course for uh, community midwives. That's my dream. To somehow the material over the years I put together a lot of materials. I've got it from here, there, and I've made courses. I've got a curriculum and everything. My dream is to make this curriculum available for community, for women, for midwives who want to work in the community.
Yeah, understand. So how do you think, like, what do you think that the possibility of it materializing on ground?
I don't know.
What are the challenges?
Well, one of the things we are now we've made a new health center, a much bigger one, and as you have in medical colleges you have nursing schools attached to a medical college. So why can we not have like a community midwifery course attached to our health center? That's the sort of we've got now a building in place to do it, and
So
it'll take me around 5 to 10 years to put that into place.
but from now on you need to then work with the government. How about collaborating with the government and then work on it, start working on it, otherwise
Yeah.
it may take very long.
I know.
So Lindsay, like, you have put up your very hard work of last 3 decades into a very simple 40 minutes journey. You have shown it as if it was very easy, but everyone knows that with such a huge success, it's not a bit of this, it's not that easy, So who has been your biggest motivation or supporter?
Our women, the members of our women's groups.
So the local, actually it was a felt need by the local, so
Yes.
acceptance was there you didn't struggle for the acceptance, you didn't struggle.
They were our supporters.
Mm.
There was no they forced me into many things. In fact, they are now we have the women's groups. They have their own autonomous cooperative, and most of the leaders of the cooperative, they're also health workers, our Swasakis. So they make sure that the health center continues to reflect their needs. In fact, they have decided they decide the service charges. And they have also decided that the service charges for members will be less than non-members. So, they are,
Yeah, one just personal question, Lindsay, like you being from out of India, did you face any challenges because of your origin? Not at all. Very
till
good.
now, no.
Yeah.
Till now.
No, like right now everyone is aware and everyone has that acceptance and all, but you have started way back in 1982 and practically from 94 you started, so those days, and in a very interior area of Jharkhand. So that's why I was asking. If it had been in a city or town, then yeah, we can understand. People are used to having from different countries, but
No,
remote area.
I think
That's very good.
I think acceptance is more in this area, and I have had less problems of being a foreigner in this area than if I go to places like Delhi.
Okay, so that, because people are very simple, and the thought process also is very simple, and the people are what would we say, more honest, and they don't have any like what negative thinking, not exactly negative thinking, but then yeah, in the interior, people are very
Cordial.
cordial.
Accepting.
Plus, they don't. They think others as they are, like pure.
They are, but less so than the cities.
Mm.
Yeah.
So,
So
Lindsay, I have
good to
yeah,
hear. Good
Dalma,
to
any
hear.
question from your side?
No, not from me. Yeah, someone is asking, can you get
Yeah.
any help from
Hello.
Indian government? How about government help to your center? No
The
government.
things that we get are Janani Suraksha Yojana is the only help that we get.
Okay.
Otherwise, nothing much. Yeah.
Yeah. So, Lindsay, I have a question. When we are in clinical practice, we suffer a lot with the non-compliance with our verbal instructions and health education, which we've been providing to our patients. So, how do you manage, and especially we are suffering despite sometimes people are well educated. So, how do you manage with those things?
Like we have one of the protocols that we follow. I don't know whether this will answer all of what you're asking, but one of the protocols that we have is that everything is documented and everything has to be double signed. So for any, there's one person can make a mistake, but two people making the same mistake is unusual. So for any intervention or any examination, two people have to sign. So in a way, there's a lot of checks and we have tried as far as possible to make as many checks and balances so that there's no the chances of slipping through, and because I think also because we have got a medical officer in as part of our team, and but it's ultimately it's the nurses who are delivering the care and administering, if needed, the medicines as well.
Yeah.
So, and I am also aware that I'm not a medical person, and they're also, most of our nurses also don't have paper qualifications either. So that makes them even more cautious that they will not do anything which is even slightly. I think our doctors make many mistakes, because as one of them told me, we have got a certificate to allow us to do that. We don't have, so we're very cautious. So I don't know whether that answers your.
No, thank you very much, Lindsay, for taking us to that side of quality, and we are very impressed. People who are, belonging to quality care and quality improvement system, they understand that this parameter which you are talking about is very important. Double signing, definitely, this save our system from making major mistakes. But my question was, how you mold people to follow your instructions, because we are sometimes finding it very difficult to we keep teaching good practices to the people and especially the patients. Let me tell you, I'm sorry, you are not dealing with patients, but definitely how you are making those mothers to follow the right instructions. What are your strategy to giving them a health education, because you are working in a very difficult area.
See, most of the women, the things, if we give some advice or suggestions to a woman, okay, say to eat something or to take some medicine or to take rest or whatever, you're giving some instructions or some advice that it would be better for her to do this. Most of the time she accepts, but the family is not a homogeneous entity. The mother-in-law may object, the husband may not cooperate. So this is where we have the Swasthakis and our community health workers. They go into the house of these women in the community. So somebody's saying about antenatal clinics. We have around 2,000 antenatal cases per year, and half of them they deliver in our center. So most of these women are coming from the villages where we have these women's groups, and our community health workers and swasthakis visit them in their homes at least 3 times during their pregnancy. Because in our health center, you, you don't get access to the whole family. You cannot see their home situation. But if you go into their homes and do counseling, which is what our community health workers and swasthakis are supposed to be doing, then a lot of these problems are taken care of. Because ultimately, everybody, you start off at the lowest denominator is everybody wants a healthy baby. And everybody wants a healthy mother. So you start off from that, and then it takes a long time. It takes a long time.
Thank you.
You know, sometimes counseling, it takes, over an hour. So over an hour in our health center is very difficult to do. But over an hour in the village, in their own house, is much easier.
Yeah. Thank you very much, Lindsay. It actually answered my question. Over to you, Shri ma'am. Unmute yourself. Shri ma'am, you have to unmute yourself.
Unmute.
Shri ma'am, you are still muted. Krish, can you check? Is she co-host? She was. Ma'am is with.
Fine, I had to.
Yes, okay.
Lindsay, thank you so much. And I was so impressed because I actually, being a nurse, I teach sociology. I see you as a sociologist who converted yourself to becoming almost a nurse. This is very, very interesting because this just confirms to me that sociology is extremely important. Because see, the last thing you said about the mother-in-law may not agree, the husband may not agree, things that nurses must know. And we try to teach them this, that what are the 6 institutions of society and how family and culture and affect health. And so I'm amazed to meet somebody like you. And one question, or I should say you've answered it, that these women whom you are dealing with, who are not highly educated, it's a strong movement. And like we are city born, city educated, and we haven't had a thought of these kind of requirements. So the women are very strong in putting together their health needs. These are just the observations I had to make. Thank you so much.
In our health center, many a times women and their families who come for childbirth, they ask for the name, they give the names of our nurses, where is so-and-so, where is so-and-so. They very rarely ask for the names of the doctors. And sometimes this upsets some people. But they feel much more, I think during childbirth, the woman needs to be as relaxed as possible, and she needs to feel, in a way, the women who are caring for them and the women that are being cared for, they're almost at the same, they're of the same community. They're not outsiders. They're not, sort of so high above them. They're more or less at the same level. And yeah, it helps, I think, during childbirth to have that. Yeah.
Totally agree with that. Yeah. Shri ma'am, would you like to say something? Well, there is a question, Lindsay. I really wanted. Yeah. Over to you, ma'am. Unmute yourself, ma'am.
Yes.
Yeah, Shri ma'am, आप unmuted हैं.
I I because my thought process went up.
I'm I'm feeling there is some network problem from the Srimam side. By the time, Lindsay, I request you to answer this question. A&M, there's a question from Levi, that A&Ms are authorized to give essential drug and first line antibiotic that cover injection 80.
No. Rupa, Levis was answering somebody else's question. Somebody was asking, what about injection TT? So Levis was answering that, I think. Is it so, Levis?
Yeah. Can you ask this question to like
Antenatal mein.
A&M are authorized to give essential drugs and first line of antibiotic, Lindsay, at your center, moreover, to give a TT injection? Because this is the second time I'm getting this question on the chat box.
Yeah, they A&Ms can give.
Okay. Yeah. With that note, we are just 3 minutes to reach 6:30. With that note, I really want, Lindsay, a take-home message from you and a message to the nursing fraternity, or you want to give to the healthcare professional from your side. Over to you, Lindsay.
Only one. Well, okay, one, I did make a couple of notes. One is that change takes time and there's no shortcuts. Many times in people who come for 3 months or 6 months, experience and exposure, they want quick things to happen quickly, and things don't happen quickly. Things take a long time. I'm here for 20 years and I've seen changes, big changes, but it's 20 years. So, things don't happen very fast. Another thing is, I'd like to say is that we should not dismiss people's beliefs and practices and traditions. We have to sift through. Some of them are harmful. We sort of somehow work around them. Like we had an issue of not eating rice. So initially we said, okay, don't eat rice, so eat khichdi. So it was not taking it head on, but at the same time, we cannot, rice here is a staple. People not eating rice for 3 or 6 days, it's like you're starving people. So we didn't take on the tradition head on. We sort of somehow we go around it. Nowadays, that's gone. Now people are eating rice because it only takes people, 1 and 1 is 2. So khichdi is also rice. So it's, so one is that, not to tackle things on head on. And also many of the things, if people have been doing something for a long time, maybe there is something positive about it, Let's not just, oh, that's an old-fashioned thing. So, maybe there's something there. So I think, be inquisitive, and until you see something very harmful, then let it be. Because we should, let some traditions, they feel better with their own. Let it be. Don't try and tackle too many things in one go. We have bigger fish to fry, so let us concentrate on the real harmful things and let some things go, and let's take on some of the good things and strengthen those things. And thirdly, what I've been saying throughout is that childbirth should not be made into an illness. These are the 3. That's enough.
Yeah, excellent and well said, Lindsay. Your last piece of advice was excellent, let me tell you. And we've been looking for something like that. These all things are everybody's in mind, or maybe in a subconscious mind. But when somebody says it's actually re-emphasizing the same thing. And thank you very much for raising these valid points. Be respectful for the people. And first of all, have you noticed that Lindsay didn't use patient word? throughout his talk, and it's very difficult for us to accept human being as a people, because sometimes in our home we used to call our family member also patient, because this term, we have to be very judicious and very cautious while we are using terminology, and that is how we get closer to the patients. So being a community worker, it's very important that they are not calling them patient. Moreover, be patient with the people, give respect to their, practices, whatever they are doing. Please be respectful and try to find the scientific fact for those practices, that they are, if they are doing that wrong, then definitely they are going to understand no, this is not a right practice, we should follow the right practices. So I really wanted to thank you once again, Lindsay, and thank you everyone for being on the show. And this was a fantabulous show I ever had, because we are listening your live experience, and let me tell you, it was actually difficult, your whole 20 years life story within an hour, but still you actually justified it so well that we are not having much of questions. With that note, I really want to thank each and everyone for making this show successful and giving us so much love. And thank you very much, Lindsay. You're doing a great job, and we are really grateful to you. Out of nursing fraternity, we really wanted to, fold our hand and want to say thank you for doing your great job. Thank you, Lindsay. Thanks once again.